They're also putting their information in the chat. If you want to go ahead and introduce yourself in the chat, that would be wonderful. Also, if you haven't attended ComNet before and would like to get on our list, you can feel free to put your email in the chat and we will make sure to get you added to the list.
Monica, do you have the slides for anyone who isn't normally on the list that you could drop into the chat?
Okay, let's go ahead and get started. Again, if you could rename yourself using those three dots at the corner of your picture, and you can rename yourself with your name, your pronouns, and your organization or agency, or if you're a family member, you can indicate that. And most of the session's going to be interactive, so during those portions, we welcome you to turn on your camera and unmute yourself. But during this first part, it's probably best to keep yourself muted and your camera turned off if you're not speaking. But please feel free to raise your hand if you have a question or would like to share something. Okay, so for those that need sign language interpreters, we have spotlighted them, and their names are Samantha and Vanessa. And you can send direct messages to them if you have any issues. Also, this is a little bit different than our normal ComNets because we're going to have a lot of breakout sessions for more interactive activities. So if you do need sign language interpretation, if you could also message Linda Ramirez, and she will make sure that then the interpreters would get put into the breakout rooms with you. Okay, and when you are speaking during this meeting, for the sake of our interpreters and for everyone in the meeting, please try to speak loudly and clearly and at a moderate pace. And please try to avoid any idioms, jargon, or technical vocabulary. I will try to avoid those as well. But also feel free to call us out if someone uses a term that you're not familiar with or an acronym. Please go ahead and ask that question, in the chat, and we will make sure we answer it for you because there is lots of jargon and alphabet soup in our world. And also, please state your name when you start speaking for our interpreters. I did not do that. My name is Monica Berg. So if you would like to view live captions, you can click on the arrow next to the show captions button. And you have the option of choosing from subtitles, a full transcript, or both. And you can also adjust the size of those captions or hide them if you don't want to see the text. Okay, and if you need any help with interpretation or any other accessibility issues, again, please direct message Linda Ramirez, and especially if you need interpretation for the breakout sessions. And thanks so much to our interpreters. We're so happy to have them here with us today. Okay, so this is our communication network meeting for July. A little bit of a different communication network meeting today. Rather than having mostly presentations from different folks, we're going to be doing a more interactive session today. So the first hour will be uh, some presentations, and then the rest of it will be interactive with breakout groups. Okay. Again, your name, pronouns, and affiliation in the chat too, as well. You can introduce yourself in the chat. And then we have a little icebreaker you could put in the chat too, which is, what is your favorite refreshing summer beverage? I personally love mint tea in the summer. It's very, very nice and refreshing, like iced mint tea. Um, let's see. And again, if you're new, please put your email address in the chat so we can make sure you're added to our future communications network list. And this meeting will be recorded except for those breakout sessions. Oh, lots of stuff in the chat about favorite beverages. Ooh, frozen yogurt milkshakes. I like a sweet lassi, which is kind of like that. Um, Kombucha. Blackberry and huckleberry refresher tea. Strawberry lemonade. Lots of good stuff in the chat there. Yeah, I'd like to start with a land and labor acknowledgement. We at the Children with Special Healthcare Needs team at the Department of Health recognize and honor the original occupants and stewards of the land where we all individually and collectively gather. I personally am up in Whatcom County, which is the traditional lands of the Coast Salish people, including the Lummi and Nooksack tribes. We honor the survival, the adaptation, the forced assimilation, and resilience and creativity of Native peoples, past, present, and future. We encourage our partners to consider their responsibilities to the people, the land, both here and elsewhere, to stand in solidarity with Native, Indigenous, and First Nations people and their sovereignty, cultural heritage, and lives. We also want to pause and recognize and acknowledge the labor on which our state and country and institutions are built. We remember that our country is built on the labor of enslaved people who were kidnapped and brought to the U.S. from the African continent and recognize the continued contribution of their survivors. We also acknowledge all immigrant labor, including voluntary, involuntary, traffic, forced, and undocumented peoples who contributed to the building of this country and continue to serve within our labor force. We also acknowledge all unpaid caregiving labor. To the people who contributed this immeasurable work and their descendants, we acknowledge their indelible mark on the space in which we gather today. And it's our collective responsibility to critically interrogate these histories, to repair harm, and to honor, protect, and sustain this land. And this is one that I've adapted from Seattle Colleges. And if you would like, you can share in the chat the land on which you are occupying. Okay, here's our agenda for today. So we're going to have a brief kind of overview of some of the care coordination work that we've been doing and what care coordination means for children and youth with special healthcare needs. Then we're going to have an example from Ian Scott from the Washington chapter of the American Academy of Pediatrics on some of the work they've been doing around coordinated care. And then the rest of the session is going to be a care coordination strategy session where we will be doing some things in the big group and doing some things in smaller groups. And we will have a couple of breaks along the way, one around 10:15 and one around 11:50. And then we'll wrap up about 1 o'clock today. And just take a second to introduce our Department of Health Children and Youth with Special Healthcare Needs team. I'm Monica Burke. I'm the Children and Youth with Special Healthcare Needs Director here at DOH. We also have Nikki Dyer with us, who's our Family Engagement Specialist. Linda Ramirez, who is our Communications and Early Childhood Consultant. Kim Schonacher, who's our clinical nutrition consultant, and Amanda Simon, who's our process improvement specialist. Okay, so I wanted to just start with talking a little bit about uh, care coordination for children and youth with special health care needs. Um, we've heard from families and we see in the data that um, care coordination is something that we struggle with in Washington State. Um, we are, really one of the lowest states in terms of families reporting that they are able to get the care coordination that they need. And so we have been working for uh, a while now on trying to improve those numbers and support better care coordination for children and youth with special health care needs in Washington State. What do we mean by care coordination? Care coordination, like everybody has a different definition for care coordination. Is it care coordination? Is it case management? Is it, navigation? We are encompassing kind of all of those aspects in our care coordination definition. So, care coordination for children and youth with special health care needs is a patient and family centered assessment driven, so looking at what the needs of the child and family are. Team based, so it's not just a one person activity. Everyone on the child's team should be involved in care coordination in some way, and it's really designed to meet the needs of children and youth. So, care coordination does not just address medical needs, but it addresses all those interrelated medical, social, developmental, behavioral, educational, and financial needs that children and families need for their optimal health and wellness outcomes. And and it really helps with the efficient delivery of healthcare related services within and across systems and help reduce redundancy. I'm going to dig into these care coordination standards a little bit more in a little while. But there are national care coordination standards for children and youth with special health care needs. And again, it looks at this kind of a team-based activity, but with a care coordinator that's a single point of contact for the child and family. And also several pieces that are kind of key components of care coordination for children and youth with special health care needs. But again, I'll dig into this a little bit more later on. So we, as a children and youth with special health care needs team, along with many of our partners, have been working on a care coordination blueprint implementation project. Um, for the past about, I think, 18 months or so. Um, and so we have a group that has family members, folks from different state agencies, folks from community-based organizations and family-led organizations, our UW partners, um, and just a lot of folks that are interested in improving care coordination for children and youth with special health care needs. And the main focus of our work as part of that project has been around care coordination. And there's three main aspects that we've been looking at. One is just care coordination in general, doing some inventorying of what care coordination programs are available in the state of Washington and what some of the advantages and disadvantages might be. We set up a family advisory council to help inform our work. And then we've also have, some subgroups that are like state agencies working together on referral pathways and cross training that we've been doing in partnership with HCA for like children and youth with special health care needs coordinators and managed care organizations and developmental disabilities case managers. Sorry. And so just kind of looking at what the system looks like and where the gaps are. And then we also have been, and this convening today is also kind of part of this project. This is one of the key things we wanted to finish with, is getting kind of broader input from a wider variety of folks on what they see as key ways that we could improve care coordination in Washington State. We've also been looking at peer support and how to better support peer support and ensure that it is seen as a critical component of care for families, and that's part of care coordination, is that peer support is always kind of a part of that, and looking at ways that families and self-advocates might be able to provide support to others. Uh, in care coordination, and get adequately reimbursed for that. So looking at, payment models like the community health workers, our partners at Lind have been looking at pathways for their family Lind trainees and looking at what some other states are doing. So we have kind of a body of work that's around emphasizing peer support. And then we also worked to give input to our partners at the Healthcare Authority that were working on developing a model for ACE Kids Act implementation. So they got feedback both from our Blueprint group plus our Family Advisory Council on best practices for that more intensive case management for children and youth with complex needs. Unfortunately, with the recent budget reductions, that has been put on hold, but at least we have kind of a model that's been developed with input from the community. And in general, just our aim for this project was to align all the cross-sector systems that support interdisciplinary care coordination, and ensure that that care coordination includes shared plans of care with a peer support component, and that really we're looking for family-centered care coordination that increases equity and access and well-being for all families. Okay, so just some high points of what we've kind of learned throughout this process. We do have a lot of care coordination resources in Washington, but there are many barriers associated with them. First of all, many are tied to specific eligibility requirements. A lot of the uh, programs for care coordination, for example, are tied to Medicaid. So if you're not eligible for Medicaid, you might not have as much access to care coordination as other folks might. Um, Care coordination also tends to focus on one program or condition rather than that full whole picture of the child. So you may have care coordinators that know really, have really great knowledge about what their system does and how to connect families to different resources within their slice of the system, but not necessarily other parts of the system. It's also really hard for families to figure out where to go. There's not like one place you go, that's where you get your care coordination. Everybody knows where to go there. There's, it's kind of like piecemeal trying to figure out how to access care coordination, or even that whether it exists. Um, and that some care coordination may be more centralized at a state level, and so or it might be, at a a major provider that's in like a metropolitan area may know really well the resources in their area, but not necessarily areas for when people go back home to rural areas to be able to access that. So different different care, we have lots of care coordination resources, but they all have their kind of strengths and drawbacks. The other thing is just that peer support is key. It should be, if it's not a peer that's doing the care coordination, definitely a peer should be connected by the care coordinator. That really builds that kind of level of trust, and you have then a family member that's kind of walked the path before and kind of knows the real world implications of some of these resources. And then one of the other big takeaways here is that we may have care coordination, but we don't necessarily have a lot of like coordinated care where entities are talking with one another on a regular basis. Oftentimes that's disincentivized, like you might be funding for just your time with the client, not necessarily your time, talking to all the other providers, like getting people talking to one another and knowing more about these interconnected systems. If we were able to really improve that, that would actually reduce the need for specific care coordination if that's kind of happening in the background. And then we have several next steps that we are going to be working on that have come out of this blueprint group. So we have incorporated this work group, we're calling our care coordination work group, into our maternal child health block grant strategies. Right now we're doing our big action planning for the next 5 years for the maternal child health block grant that funds our work. And so we have that as a strategy to continue this work group over the next 5 years to continue to make improvements in care coordination. We know this is it's a complex problem that's going to involve not just our little DOH team, but everybody that's part of the system. And so we want to continue to have a interdisciplinary work group that's looking at that together. We also, as part of our blueprint, we created some trainings. I talked about the cross trainings, but we also created a care coordination toolkit that we've done trainings at with different care coordinators on, and we want to continue to refine that and offer additional trainings on care coordination for children and youth with special health care needs. That's another one that we've put into our maternal child health block grant strategies. We also were just accepted into a TA opportunity for the Center for Medicaid and Maternal Child Health Partnerships. So we're going to be able to get some technical assistance on working with Medicaid on innovative models for care coordination, looking at what other states have been doing, things like that. So we're going to be working on that for the next year or so with our Medicaid and other partners. And we're also been working with our local children and youth with special health care needs coordinators on really defining, what is the role look like for children and youth with special health care needs coordinators in local communities and what strategies might we work on together. That's also one of our maternal child health block grant strategies, and we've been getting some support from the Maternal Child Health Workforce Development Center on what's called a learning journey to help explore that. And then we also, want to work on increasing the network cohesion and communication between care coordinators for children and youth with special health care needs. We have this communications network that meets quarterly. We also just recently started a newsletter, our communications network newsletter. So really wanting to build those resources and communication pathways between folks that are working with children and youth with special health care needs in different areas. We also have a subgroup of state agency folks that have been working on kind of like referral pathways between state agencies, like, for example, ESIT to children and youth with special health care needs to managed care organizations, things like that. And then we continue to enhance domain-specific coordination, like our school medical autism review teams that are working on autism diagnosis, a nutrition network, and we also have a type 1 diabetes group that brings folks together that are working on issues related to type 1 diabetes. And then we want to continue to work on integrating peer support and looking at how that can be, promoting that as a key element of any care coordination that happens for children and youth with special health care needs, and working on ways to make sure that peers are adequately reimbursed for that. Okay, so that's the end of my slides for now. And then I see Ian has come on camera. Ian, did you say you wanted to share your slides yourself?
If possible, that would be great.
Oh, I can't hear you.
Can you hear me now? Can you hear me now?
I can hear you, Ian. Maybe it's on Monica's end.
Okay,
We can hear you.
Yeah.
sweet. I
I'm
guess.
still not able to hear. Are other folks able to hear Ian?
Yes.
Oh, so it's
Yeah,
just me.
I can hear.
Interesting.
Okay. Also, Monica, you've disabled screen sharing for me,
Okay, well,
so
I
why
will,
don't you just drive the slides as well?
Ian, you can share yours. I've made you co-host, so you can share now.
Okay. All right, great.
I'm going to stop sharing.
All right, can you all see this?
Yes.
All right, awesome. Well, hello, my name is Ian Scott. I am a program coordinator here at the Washington chapter of the American Academy of Pediatrics. I'm really excited to share some of the programs that I've been helping out with over the past 6 months. Before I talk a little bit about the specific programs themselves, I want to center ourselves in some of the Washington chapter of the AAP values. Our 3 values are advocacy, equity, and collaboration. And collaboration will be what I'm talking about today. So, the first program that I wanted to talk about is called Partners in Student Health. And this program is looking at supporting schools, local health jurisdictions, and pediatric primary care provider collaboration. This is the animating question that Dr. Maria Huang, a pediatrician that started this program, began with. How do we foster relationships and trust in times of transition? At the time, she was living in Lewis County, and COVID had just started. She began to coordinate meetings between local health officers, the public health director, pediatric primary care providers, and school superintendents. And the goal of these weekly Zoom meetings was to streamline communication between the clinics and schools with the goal of a quicker return to in-person learning. And there's 2 primary ways that they thought they could accomplish this. The first one is to have school-based COVID vaccine clinics and COVID testing sites at school. And the second one was a letter to the community encouraging continued vigilance as community cases of COVID increased. Now, this letter to the community was much more expansive than the previous stakeholders. It included pastors, fire chiefs, police chiefs, different restaurant owners. So really trying to get the whole entire community on the same page with their health policy and know that everyone was kind of on the same page. This then expanded into 3 current partnerships that we have right now. The first one is in Thurston County, and as of June 30th, we've had 3 meetings in Thurston County. There was a meet and greet in 2024, and then a back to school planning event. And then, as you all know, measles has been a topic top of mind. So we recently had an infectious disease talk in the spring of 2025. In the Thurston County, we kind of had a sub-project, and this was the bidirectional consent form. And this was kind of a deep dive into how we do data sharing between schools and primary care practices. And the main question was, why is there so much friction? There should be an easier way to do this. We specifically focused on kids with chronic illnesses, as these kids often had a time in school, whether that be them having diabetes, allergies, and they would have an emergency at school, and the school nurse would call the primary care provider. And once they got through the phone tree, the front desk person said, "Oh, sorry, we can't share any information with you because the parents haven't consented to share information with the school." So our goal was to try and come up with a form that potentially we could put back to school pack where everyone is signing a bunch of forms so that the parents consent to sharing the information between the pediatric primary care providers and the schools. And there's a couple of next steps that we are thinking about with regarding this bidirectional consent form. We could possibly include the specialists. This is especially pertinent for kids with chronic illnesses, as they often have many different specialists that are working with them. We also realized that some of the electronic health records that the pediatricians were using already had these forms built in. And then also the bidirectional consent form that we were using also had a couple of legal hurdles to get over. So we were interested in seeing how that kind of plays out. But through this collaboration, one of the big things that we all realize is that we operate in very complicated systems. And for example, the pediatricians thought that the school nurses, it was like a much more simple job, but they were learning that there is a very complicated school nurse administrative infrastructure. Next, on to Northeast Tri-County. This is a more recent collaboration region. We actually just met this past Tuesday, and our goal is to have an in-person event sometime in the late fall, hopefully somewhere in Newport. And the goal within these 3 different counties is to have a champion from each of the stakeholder groups. So our goal is to bring together the schools, public health, and the pediatricians. And so if we have a champion from each of those stakeholder groups, they can kind of wrangle their colleagues to show up to these in-person meetings. And then finally, Clallam County. We had a meet and greet event on May 6, 2025. And yeah, this was a very encouraging event. We had 24 people show up, and it was really encouraging to see some of the pharmacists working at the local QFC to show up to this meeting as well. We're looking to expand from these 3 locations. The first one is in Lewis County, where the project all started. However, as you all probably know, in the healthcare sector, there's a lot of turnover, so there's probably going to be some new faces. Additionally, we want to expand to Jefferson County, which is just below Clallam County on the Olympic Peninsula. And the public health at Jefferson County was actually included in the planning for the Clallam County meeting, so they kind of have seen some of the back-end administrative work. And we're also looking to expand to others. We found that this is a highly effective way to provide basic services through community-led design in a funding landscape strapped for money. As I was exiting the Clallam County meeting, a public health official turned to me and said this quote: "This program allowed for our community's genius to thrive." I think this highlights the core ethic of this program, which is to listen first, then act. We are majority working with rural counties, and there's nothing that maddens people in rural counties than someone else coming from the outside and telling them what to do. So our goal as the Washington chapter of the AAP is to provide the back-end administrative work, the advertisement materials, and the program coordination skills so that they can set the agenda and address the community's most pressing needs. Some of the impact from this program, as I mentioned earlier, it helps streamline communication, promote collaborative problem solving, and prevent the siloing of work. And this is especially important in a funding landscape where there's not a lot of money. We really need to focus on this collaborative mindset. The second one is a digital directory. At the beginning of each meeting, we had a sign-in sheet, and we asked each person who attended the in-person events to list the best email and the best phone number to reach them. I don't know if you've had any experience with phone trees, but staying online for 20 minutes before you actually get to talk to a person is kind of annoying. So having the best contact information for the people that you want to talk to is really, really helpful. So in Clallam County, we have a digital directory now of close to 70 people, And we also have one in Clallam County with the 25 people who attended our in-person event. And we view our position as a Washington chapter of the AAP as a very unique position. We can help share strategies from different counties. Oh, this worked in Lewis County, this worked in Thurston County, this might work for you guys as well. So yeah, I consider myself a very privileged position to see this program be implemented in a bunch of different locations. And in each location, it's different. And I think that's part of the beauty of the program. I wanted to end with a little story that came out of our Clallam County meeting. One of the school nurses from SQUIM previously had a program that came and did all her back to school immunization program, but that funding program got cut. And for all of her August and September back to school event, she was looking for someone to do that. And literally a day after we had the meet and greet, she connected with one of the public health officials, and they set up 3 back to school immunization programs. So this is just a testament to the power of collaboration, and basically helps the public health get immunizations into arms, and then also prevents measles and other infectious diseases from spreading in the school. I wanted to end with a little tagline from the Washington chapter of the AAP, which is advocating for kids, adolescents, families, and all who care for kids. I think you read our name, the American Academy of Pediatrics, and you think the information is just for pediatricians, but I want to stress that all the information in the programs that we do is really focused on all who care for kids. Thank you for listening to my presentation. If you would like to learn more, here's Dr. Maria Huang's email, my email, and then my fellow program manager, Lori Gosselin's email as well. And I'd be willing to field any question that you all have for me. And yeah, thank you for having me today.
Well, thank you, Ian. I appreciate that presentation. Does anyone have any questions for Ian? Stephanie's requesting to see the contact slide again. And then we have one question about who was involved in Lewis County, but it looks like Kate has already answered that in the chat. But if there's any other contacts besides Maria
Yeah,
Huang.
I think Ashley O'Neill is currently coordinating the Lewis County one, and I can drop her email.
Okay, well, I'm not seeing any more questions coming in. This is exciting work. Yeah. Lots of love in the chat. Lots of thanks. Sue says it's another example of people working hard with the same goal in mind. Catherine asks if you could share the forms you created with the schools. Yeah, the bi-directional form. Lots of folks would like to see that.
Yeah, of course. I will see if I can attach it in the chat.
I wonder if you might be able to share your screen and show us a little bit of what it looks like. That would be interesting.
Yeah. Yeah, I think the big thing with this project was the HIPAA and FERPA regulations are very complicated.
Yes.
And we also found that putting this at the beginning of the school packet might be an easy way for people to, instead of the school nurses having to track everyone down halfway through the school year to get consent. Let me.
Yeah, one of the things I do really love about this project is that thinking about, taking that burden off of the family to go and get all those all those consents, and families are often,
All right, so can you all see this? All right, so on one side we have the FERPA consent with the student name, the date of birth, address, school point of contact. And then here we can put in the school staff, the healthcare team members. So this is where we could potentially expand to like, okay, like you want to put in your neurologist, your cardiologist, your allergy specialist, rheumatologist. That could be a good place to put it. So on one side we have the FERPA consent with a parent and guardian name. And the idea with this is to have have maybe a little dialogue box too, with the in the electronic health record to say like, oh, like this patient has actually consented to share information with the schools, and so it's really easy for the pediatrician or the family practice doctor to see like, oh yeah, if someone calls, we can share information with them. But as I said earlier, there's probably a lot of legal hurdles that we also have to go through. And we haven't really consulted. This was from the national chapter of the American Academy of Pediatrics, and I think they consulted legal counsel, but I think in each state there's a little bit of different laws that you have to kind of work around. So definitely still in the process, but hopefully can reduce some of that friction that I was talking about earlier to make things a little bit easier.
let's see. So Kim, you had a question there.
Oh, I
about-
just wanted to ask Ian if there were any people that he felt were missing from any of the groups. I know he had some core ideas of who should be there, but I'm just wondering if there's any missing people that you've had a hard time connecting with. This might be a great group to reach out to find those people.
Yeah, I think there's two preliminary thoughts in my mind. The first one is in all locations, the pediatricians were the hardest to get a hold of, partially because they're so busy. And a lot of the in-person meetings were after work hours, so it was usually 5 to 7. And yeah, it was, I mean, they just have a lot on their plate. So definitely a little bit hard to get them in the room, but they just add so much because they see so much. And then the second one is, um, I think it would be really good to have some parents as well. Obviously, we have a bunch of medical professionals and people who are very involved in this space, but I think my always question is what blind spots am I not seeing? And I think having some family voices in the room definitely will mirror some of the blind spots that we might overlook because um, all of us are very comfortable navigating the healthcare system, and I think having someone who's not necessarily the most comfortable navigating the system and all of the forms and acronyms, if we can have that perspective in the room as well, I think that would be a big value add. So I think those are the two main ones.
Okay, let's see. So just several comments in the chat. Sherry says that they could use some assistance in Stevens and Ferry counties with this type of support. Her ARNP is getting in the process of getting COE certified and has taken the trainings, but is still working on next steps for the actual certification. And Melina also has a mobile unit for any community health needs for vaccinations or other emergent care needs or assessments for ongoing referrals. And Kate's pointing out that the FERPA HIPAA barrier is a big one for the Autism Centers of Excellence that are hoping to collaborate with schools. So yeah, this bidirectional form is it's a really helpful tool. So he's talking about developing consistent, inclusive language that encompasses kind of the full range of chronic disease and IDD and behavioral health.
Yeah, I guess I can also speak a little bit to some of the themes that we've seen pop up. So at the end of each meeting, we ask like, oh, what do you guys want to talk about next time? And school avoidance has been a really, really big topic. Why are children not showing up to school? And the general sense is that's really tied to behavioral and mental health. And so I think both in Clallam County and in Thurston County, we're going to be talking about school avoidance coming in the fall. School med authorization forms was another big one. IEPs and 504s was another common, highly ranked topic. And then vaccine access and how to talk to people with vaccine hesitancy, I think, was the third most important topic that kind of arose between the three locations. So.
Is it okay if I ask a question? Oh, sorry, I
Sure,
think I
go
see a
ahead.
raised hand though, so I don't know if Catherine wants to go first.
Okay, go ahead, Catherine.
Oh, I was just saying, I just think some of the topics that families are expressing and providers are expressing as needs are pretty common. I'm just curious if there's ways to access either the information that you share or just having the perspective from the AAP, I think could be really helpful at the local community. So if you're developing something in one community, is it possible that we can just share it or use it in another?
Yeah, so this question has been a fascinating question for me, as I've been focused mainly on the program coordination side, and now I'm thinking about how can I share what I've done. And I think the first thing that comes to my mind is we have a monthly newsletter called Developments, where we share a lot of the stuff, both from the American Academy of Pediatrics, and then also what we're doing here in Washington State. So that might be a really great place to start. I'll also put my email in the chat. Yeah, I think the other thing that we're thinking about is what are some other communications channels besides email? Because I don't know about you, but I am kind of sick and tired of reading emails. So what are other, maybe like a video format, and especially thinking about literacy. And I think a lot of our health information is at a pretty high reading level. So maybe having someone speak about it might be an easier way to share the information and what's actually going on. So one of the things that I've been thinking about is actually starting just a weekly Ian talking to the camera. And that might be an easy way to share, whether that be through YouTube, through Instagram, through Facebook, an easy way to just get a summary of what our organization is doing on a weekly basis. But I'm also open to other ideas because I think this is something that even for our members that are part of the Washington chapter of the AAP, sometimes they don't even know the work that I'm doing. And so, yeah, it's kind of been a challenge. But I think one of the things I've also been thinking about is how can I leverage local media outlets? And that kind of opens a whole nother can of worms with the demise of local journalism and local newspapers. Um, so, but yeah, if you guys have any ideas of how to share information that we're learning in different counties across the state, I think that would be really, really helpful. Like if there isn't a newspaper in your town or city, where do people go to look for information? Because our information ecosystems have been changing pretty rapidly, especially post-COVID. So it's exciting, but also a little bit challenging. So hopefully that answers your question. Mari, what was your question?
Hi, yeah, so my question, so it's really wonderful work you're doing. I kind of get the sense that a lot of this collaboration seems like it can be developed well in kind of the more rural counties and um, just kind of thinking about, for example, when because I'm a dietitian and some of the work that I do is looking at care coordination coming from the NICU out into the community. And it seems like some of those systems are really well developed in some of the more rural counties, just because, fewer kids, but also there just seems to be better networking and connection among like the hospitals and the WIC and like the local health jurisdiction. And so when we think about the more like larger counties, like say King County, I just wonder about how, I mean, I would imagine that it has to take a different model, but yeah, I'm just curious if you kind of thought about how would this kind of care coordination look like in like a larger county?
Yeah, I guess the underlying question to that question is how do you form relationships at scale, right? And because that's the real focus of this program is how do you form relationships? And it's much easier to form relationships if there's only 25 people in the room instead of 550 people in the room. Um, My first, I guess it comes back to my answer to the previous question is like, where do people go and look for resources? Is there like a centralized location that the families, the pediatricians, that everyone goes to that like, okay, this is our trusted source. This is where we're going to find the resources that we need. Um, and one of my worries right now is that we have a splintering of where people are going to look for their resources because there's so many options. And so maybe the first step to think about how this might happen in King County, for example, is trying to piggyback off of where are the places that I think of like a watering hole? Like what are the watering holes that people are getting their information from already? And how can we piggyback off of that? And are those watering holes physical spaces? Are they digital spaces? And how can we um, highlight those spaces and like basically point all of the different systems towards that centralized location where like, okay, you can go here, you can go here. These are the relationships that you need to form. Um, and then I guess the second part of that question also addresses the turnover question of the fact that like a lot of these, especially in the entry level positions, who are doing a lot of the relationship building with the patients and the families, they're only there for 2 or 3 years and then they're on to their next thing. Um, and so I guess my question for that is if there's a lot of turnover, what are the onboarding processes? And how can we create that onboarding process quickly and get um, those people who are onboarding plugged into those big networks and be like, okay, these are the people that you really need to talk to be able to do your job really well. So yeah, I guess centralized information, and then also what does the onboarding look like if there's a lot of people, and maybe those two things might help form those relationships at scale. But I don't know, those are just a couple ideas off the top of the dome.
Great, thank you.
I love that watering hole idea. That's a great thing to be thinking about. Yeah, and we got some suggestions.
I'm gonna, this is Renee, and just real quick, I love that idea of the,
Yes.
watering hole, and also this is what you need to know to do your job well. Because I feel like I used to do family resource coordination work, and I was so busy trying to gain all the information so I could do a better job, but I also was living it. So it also helped me be a better parent of a child with quite a few needs. And a way to think about how we say in the beginning, according to the job, this is why it's beneficial as FRC, family resource coordinator in the Birth to Three system. This is why this is relevant. This is why it's going to help you do a better job. These are the areas you need to know about. And now, in order to be able to help a parent understand how to coordinate for their child by the time they leave our program. I think about DDA, I think of pediatrics, I think about the medical home, I think about Chitskin, I think about, and even understanding the system and what that's supporting. So anyways, I like what you're saying on that.
Thank you so much for the question. Such a good question. And I think also a question that merits more thought. And as things change, that the answer to that question undoubtedly will change as well.
Thank you so much for this presentation. I think this has been a kind of great jumping off point, some examples of things that are happening in communities around the state right now to improve care coordination, but obviously highlights how much more there is to do. But I just really love that cross piece with the schools, because I think that's just one thing that we hear over and over again is, it's really challenging both on the school end and on the provider end to make those and maintain those connections. And also, generally when those connections happen, it tends to be because families made it happen by going and getting all those. So I love some of the things that you're implementing there. I also wanted to call out that Bonnie put information in the chat about a conference coming up at the end of the month. This is one that is by the Washington State Developmental Disabilities Council, and it's really focused on that intersection between behavioral health and developmental disabilities. So highly recommend folks to check that out and register for that conference if you're interested. Thank you so much for putting that in there, Bonnie.
You're welcome.
Okay, so let's see. I think we're going to transition now. I'm not seeing any more questions for Ian, so I am going to move over to I will share my screen again here. So we're going to start with some, I'm sorry, just trying to find my share. All right, just one second here. So we're gonna start, we're gonna be in breakout rooms for most of the day here. And so we wanted to start out. We're gonna try and keep you in the same breakout rooms all day today. So we wanted to start out with a little impromptu networking activity to help you get to know the other folks that are in your breakout group and what what their perspectives are, and just also just give you a chance to reflect on what you hope to contribute to this meeting and what you hope to get out of this meeting. And then we'll reflect on that a little bit after our break. So we're going to have about 15 minutes right now for you to go ahead and and get into breakout groups and discuss these 3 questions that are on the screen now. I will also put them in the chat for you. And Linda, how are we doing on breakout rooms? Let's see.
They're good. They're okay. Yeah.
Okay, so I think we'll go ahead and let you off into breakout rooms and just take about 15 minutes to introduce yourself to the other people in your breakout group room, and then think about these 3 questions. And it would be helpful if you can have someone in your room that is that can kind of do a little maybe report out on kind of key takeaways from your discussion.
Can you give me like 5 minutes, actually?
Okay, sure, that's fine. I'm going to go ahead and put these 3 questions in the chat. I also see that, oh yeah, people are joining in the Teams meeting.
There we go. I thought someone was ahead of me, but I'm happy to go.
I thought so too.
All right, thank you. Not everyone had time to speak in the group I was in, but it was great to see the variety of people there, and I think just the eagerness to connect and share across the whole geography of the state, and that kind of valuing the personal networking piece, and knowing what we can learn from each other, and how it can be supportive to the families that we work with to have those connections. So I'm hoping, I don't know what is going to come out of this meeting, and I'll have to leave before it's over today, but I'm hoping there'll be ways to extend that out. I don't know, through email connections and understanding a little bit what people do in their roles. And yeah, and the other reason I raised my hand is because one of the things I shared with the group is, in my role at the Autism Center at Seattle Children's, we develop a lot of patient education materials and translate those often into multiple languages. And those are publicly available on our patient education database. So I'm going to share a link to one of the recent things that we developed, which will also be a link to that database, which is searchable. And I want folks to be aware of that, and access that link and search it and explore things, and let us know if you have comments about them. And we have our email address for our team at the bottom of the pieces. So And I'll drop it into the chat as well. Thank you.
Wonderful. Thank you so much, Joy. That's very helpful. Maddie?
Hi. Yeah, so my name is Madeline Jensen. I was telling my group that I'm new to this role, and I come from a very small community, and so really um, navigating all these things. I just really wanted to say that within the group, it's just so cool to see all these different roles and all these moving parts, that we're all working together and to reach a common goal. So that's just really neat to me. So thought I'd share.
Thank you. Okay, I don't see any other hands raised. I see Kate's put something in the comment about her group, just wanting to learn about other communities and what's
Looks like
happening.
Emily has hers on.
Oh, okay, Emily.
Hi, I'm Emily, and just reporting from our group and some of the themes that came up. There was observations about the decline, really over the last few decades in the ability to provide services in a coordinated way through public health. And so then now trying to navigate and figure out ways to find supports across systems, figuring out questions about how do we figure out how family resource coordinators, FRCs, work in the current systems with new laws and things that are changing all the time. The goal of maybe having a more clear, consistent system across the state for setting up care coordination. Again, that kind of goes back to something that has been there before and is lost, but we don't have the same resources and support, so hard to know how to put it back into place. And then again, back kind of to that watering hole idea that Ian had brought up of how do we reach people, but then also how do we build trust? Because that seems to be a current struggle. Thanks.
Thank you. Okay, I think that is all the questions.
And Joy has her hand up too.
Oh, I think Joy, is that just from before or did you want to make another comment? Okay, thanks. Okay, well, with that, we're going to go on a short break. We'll do about 10 minutes and come back at, let's say, 10:39.
All right.
And I'm going to ask one of my lovely teammates to monitor the chat. So if there's any questions, we can answer those in real time. So this is the tool. It's called Mural. And this is going to be the entire workspace of Mural. And I know those of us who are a little bit more tech literate, this seems like a lot, and it can be. So I just wanted to take us all the way out and show everybody this is what the whole thing looks like. Really, when you go into your breakout rooms, this area, I'm moving over with my mouse. Right here, this is where we're going to be focusing on for you all. And if you pop in to the mural and you are, let's say, completely blank and you're like, where am I? I don't know where I'm at. There is this thing down here. It's called the map. It's in the lower right-hand corner. It shows where you are. Monica is green, so she's up here, but I'm down here, and you can see I'm not near the content currently. So you can click into it and it will bring me back to where the content is. And again, in the lower right-hand corner, those tools in that toolbar are going to be really useful. This mural is going to be assigned to you through the PowerPoint. So it's going to be assigned to your specific group. So don't.
I'm putting those in the chat now for your group mural link. So if you see your group number in there, you can go ahead and start clicking on it if you want to.
Yeah. So moving through this toolbar down here, you have a zoom, like if you want to manually zoom in to the mural, you can use this zoom feature right here. And also, these are the navigation settings. This is mouse mode, which means that you can use your little circle part on your mouse to zoom in and out, and also click and move. And there's also trackpad mode that allows you to move when you're on your laptop. I have a mouse, so I'm going to go over to mouse mode. And there's also move mode. So this means that you're going to move, but you can't change anything. Previously, we had a session and people were moving things. It's going to be a little less of a problem this time because we've learned, and all of these things are locked down. You cannot move them. The only things that y'all are able to move are the sticky notes that are on here. There are sticky notes throughout, and I will take you into one.
And I see that there's some questions in the chat about which group folks are in. Yeah, thank you for Kim for sharing that info.
So if we zoom into the sticky note, you can see it's just a little square to type your information on, and you click on it, click twice, and then begin typing. Once you begin typing, you type normally, and then you click out to move away from it. Another feature is if you're looking through and you see somebody else's and you're like, oh my gosh, they've made such an amazing point, you can add a reaction to that. as well. So that is another kind of fun feature as we go through.
Amanda,
and-
can I just interrupt for just a minute? We're having a lot of things happening in the chat around what group people are in. So I wonder if we could pause just for a moment, because I think people might not be able to pay attention to your amazing instructions until we figure out people understand the group situation. People are concerned they don't know.
I don't know if there's a way to easily see which group you were in before. It's whatever your breakout room number was. So like room 1, 2, 3, 4, 5, 6.
We can also broadcast the link to them as well when they're in the breakout rooms too.
Yeah. So I know that I guess, let's see, Sarah, you were wondering what your one is. That's room 3. Is what you were in, Sarah, and then Kate, you were in room 4. Yeah, maybe I'll do some screenshots. That'll be easier, probably.
And then should we just wait to get into the groups until after we've listened to Amanda's amazing instructions?
Yes, we're not getting into groups right yet. But if you wanted to, we were sharing the links early just so that you could maybe practice along while she's doing this too.
Got it.
I'm gonna wait until all the groups are posted. Just so we all have our spots.
Thank you, Sue, for getting those in there.
Oh, Astrid, that's a great point. Thank you.
Okay, so I think they're all in the chat, maybe except for 6. There we go. Thank you so much, Sue.
Okay. I would be panicking about my group as well.
Should be in the chat for the mural. So if you want to click on the mural link for your group, you can see a mural that's just like the one that Amanda's in right now, but specific to your group.
Oh, do we feel like we need to go backwards at all on any instructions, or we were talking about adding a reaction to the posts? If there is any point thus far that is a point of confusion, I can go over it again. If not, I can continue to move forward. I'm also going to be available throughout to.
Amanda is our official mural tech support. So if you have any questions when you're in
Nope.
in the breakout rooms, you can message Amanda and she can come and try and help you out.
I will try my best to help you out. And I wanted to also, I have a little list here that I made to make sure I touched each point. If you need more sticky notes, like say you wanted something over here, you can right click onto it and duplicate it. And that's also a way to get into edit text. These are also available. You don't have to duplicate them. They are drag and droppable. You don't have to worry about keeping them all nice and neat. Please take them. It's not gonna hurt at all. Basically this time you guys can't break this one. Please don't challenge me on that though. And then The other thing is that there's this area down here that's called focus mode for our friends who don't like all of this happening. So that hides like all of the extras that will be going on. So it takes some of the distractions away. And also, it was noted yesterday that if, you know, once you get a bunch of people in one room, there's a bunch of cursors because you're going to be collaborating with multiple people if that's how your group wants to run things. There is a way to take the cursors off, and that's if you just hover over one of the people's names and you can unclick show cursors right here. And that will make it so that only your cursor is available on your screen, and it will help make it so these extra distractions go away. So I think that is all I have for y'all on my end for the overview. Like Monica said, I am the unofficial mural figure outer, and I will be happy to help you throughout. Just let me know. Oh, the other thing I wanted to tell you all, see how the sticky note down here kind of appeared. There was a mention earlier about people wanting to talk to each other further in your group, possibly share emails. Y'all are adults and can exchange emails as you wish, but you can also put it on your mural and make it copy and pasteable and make it easy to. You can just add it down here, and just put your emails, and it would be an easy way just to get them all together if you would like. Just I thought of that while y'all were talking about it for your group. So, and that is also done. There's also sticky notes tab right here, but also if you double click on an empty space, there's our sticky note. So.
And I also see, you know, there might be some new people that joined that weren't part of a breakout group before. It seems like group 6 is our smallest group, so probably new folks would be added into group 6. So you could maybe use that one. Groups 5 and 6 would be ones that would join in. Okay.
Up here is how you make the text smaller or bigger too, just as a note as well. All right.
Okay. Any other questions about mural before we go into the presentation part? Okay, so we're not going to go into breakout rooms just yet. I'm going to kind of orient you to what we're going to be doing. I'm not seeing any new comments in the chat, so I'm going to go ahead and share my screen. Okay, and I'm going to go into presentation mode here. Let me just get my chat set up so I can see it. But I would like someone to let me know if when I go to full screen here, does that go to full screen for you all?
Yeah, it looks good.
Okay, great. So, as I was discussing before, we've been, doing a lot of work with our care coordination blueprint work group around looking at best practices for children and youth with special health care needs and what the system looks like in our state. So I just wanted to go over a couple of the kind of background stuff that I put on this slide for you to reflect on during our breakout activities. So the first is these national care coordination standards. And, before I mentioned that, care coordination is really a team-based activity, and that is part of this national standard. So it's thinking about the whole, multidisciplinary care team that a child and family has, and really the child and family are the core members of that team, but they really have a variety of different types of supports around them that would be doing some aspect of care coordination. So you have your primary care provider, your specialty therapy providers, behavioral health specialists, other resources, supports, and services in the community, education partners in schools, medical specialists. All of those are part of the team that should be coordinating care for a family. But it is also really helpful for families to have access to a care coordinator that is a single point of contact for that family. So they have one person that they know they can go to that can help them like figure out where they need to go or connect to the other partners on the team that need to be identified. Then we also have as part of this model that screening, identification, and assessment is part of it. So, families need to be identified as needing additional care coordination. How does that happen? And then really doing an assessment with the family on what are their needs and what do they need support with. We also have various areas down here that are part of the national standards, including the care coordination workforce. So we have been doing a lot of work around that care coordination workforce, like trainings for care coordinators, but also HCA has been doing a lot of work around, what does that reimbursement look like with the new community health worker reimbursement and peer support reimbursement and things like that. Care transitions are a really key part of care coordination because a lot of times you don't need necessarily ongoing care coordination all the time. Those key transition points are when families need a lot of extra support. So when you're entering into the system or making a transition, let's say from birth to 3 to school-based services, that happens around age 3. There's also transitions, that happen, as a child, transitions to middle school or high school, and then the transition to adulthood at the end. So there's lots of care transitions along the way where families will need extra support. And I think we've talked a lot about team-based communication today, like how are different members of the team able to communicate with each other. And then making sure the family has the information and support they need to really understand the system and be able to navigate it effectively. And then a shared plan of care, something that is shared between different organizations that are working with the family so that everybody's on the same page about what is happening with the care for this child and what supports are already in place and what might need to be in place. And then this is one of our maps from our care coordination toolkit that kind of looks at all the different service systems that children and youth with special health care needs of their families need to navigate in order to have a meaningful life and effective care for their child. So this is one of the reasons why care coordination is so important, and having someone that you can rely on is really critical. So you have the child and their family, hopefully with a shared plan of care that's developed with that child and family's needs in mind, then someone to kind of navigate all these different systems. So we have, you know, your primary care, your medical specialist, dental care, even finding out who the care coordinators are that you might want to connect with, medical equipment and supplies, insurance, disability services, financial support services, you know, nutrition, food, advocacy and legal support, behavioral and emotional support, social support in the community, really being able to have community engagement, recreation, involvement in your community for a meaningful life. And then education is a really huge piece for children with special health care needs and their families. So there's all these different complex systems that families are having to navigate every day. And that's why care coordination is so important. Our Family Advisory Council, one of the things we did with them as part of this project is did some like care mapping with our Family Advisory Council members. And what you find often is that, you know, it is really the parent that's doing a lot of those care coordination tasks. That really is where it's tending to fall right now for families, is that, you know, in this case, mom is like trying to navigate all these different types of systems and get connected to all these different types of supports. And that's really a lot of work, and really kind of understanding what that picture looks like and what families are navigating every day is important for, you know, us as providers to understand in order to create effective systems that kind of reduce some of this this burden and work for the family. Here's another example of a care map, you know, trying to, again, navigate all these different systems: community recreation, education, legal. And it's not just the immediate family, also the extended family, social services, family supports, health. And then really, you know, even like things that there's time constraints. So you might even know about a resource, but not have time to really check it out or understand like what it can really do for you. And then there's lots of different care coordination systems that are already in place. And this is kind of a sampling of some of the things that came out of our care coordination inventory. So we have care coordination that's offered through the managed care organizations that's funded by a healthcare authority and Medicaid. But again, you have to be able to qualify for one of these programs on Medicaid in order to access that care coordination. We also have some more comprehensive case management services that are offered through managed care organizations or through health homes. But it may be challenging to qualify for some of those services. There's also specific care coordination that's involved with our behavioral health support systems that might be in place for families. And then we have our children and youth with special health care needs coordinators in their local communities that provide services in most communities for care coordination, but really don't have the capacity to serve every single child in their community and get them connected to those local resources. So how can they be more available to other care coordinators working with families and be able to be that kind of overflow for those that don't qualify for other types of care coordination. And we also have maxillofacial review boards that are special to children with cleft lip and palate. There's care coordination offered by DCYF through ESIT and Fostering Wellbeing. There's also developmental disability related care coordination that happens through DDA case managers, funding that goes out to county DD, info and education providers. And that could be things like, you know, ARCS or Parent Coalition or Parent to Parent in your local communities. And then also informing families coordinators. And then there's also lots of peer support options out there, like Parent to Parent, PAVE, lots of work recently on community health workers that might be embedded within primary care. There's peer supports associated with WISE for behavioral health. There's also Parent Coalition. And then there's some specialty that for particular conditions like HIV or AIDS. But then there's also some like models here that help to fund like community-based organizations through pathways and the accountable communities of health, pediatric alternative payment model to help support care coordination within medical providers. So we have lots of resources, we have lots that's going on here, but it's a very complex system for families to navigate. So what our next activity is, we're going to go into breakout rooms and we're going to kind of have you reflect on these images that I just shared. And you may choose to focus on a particular image in your breakout group, or you may just want to reflect on things as a whole, or maybe even your personal experiences. And the first activity we're going to have you do is a rose, thorn, bud activity. And so we have this this element in your mural that's going to be rose, thorn, bud. So we have these color coded. So the red is the rose, the blue is the thorn, and the green is the bud. So we'd like for each person in the group to fill out at least 2 for each of these categories on what you see and or experience. Again, this could just come from your personal experience with care coordination for children with special healthcare needs. So roses are things that are what's really going well. What is a strength within the current system that we want to support or make sure continues or build on. Blue is the thorn. So this would be what's not going well. What are the barriers and challenges that we see in the system? And then buds. So that's things that are maybe emerging, things that might be new that we could build on, that if we focused our energies on, we might be able to create something really helpful for families with. So you can use these little sticky notes down here and and just fill in what your thoughts are for each of those. And if you need to create more, like, hey, there's not enough thorns on here, you can just copy one of these and paste it anywhere up here and type in your own things. But we gave you quite a few response stickies that you can put your responses in. So in this next breakout session, we're going to do that activity, and then also just reflect on these 3 questions. Kind of what is really happening here as we reflect on these, like just kind of your thoughts about what is really going on in the system. What are your kind of key takeaways from looking at these images? How is it relating to your life? Either as a family member or a provider, how is that impacting you? And then thinking deeper about the whys, like why do you think that these issues exist, especially kind of the thorns or that you identified in the first activity, or just, why does the system look like this? So thinking a little bit deeper about the whys in here. And so that's the first round of activities that we're going to do. And then we'll pause there. You'll see there's some additional activities down here that we're going to do later on, but I'll kind of orient to us before we get into those things. So you're going to be basically doing kind of 1 through 4 on here, reflecting on those images. Let's see. Are there any questions? Yeah, let's see. I think Linda sent out the slides earlier, but yes, thank you for Kate for putting those in the chat as well. Yeah, and all of this is in your mural. I'm going to end this presentation now. One thing that I would is helpful. I think Amanda might have shown this, but if not, like if you want to zoom in on a particular image, there's this little eyeball here. So you can, like, if you want to re-look at the images, they're all in your mural and you can kind of zoom in on them that way. And you can zoom in and out. Yeah, there's different modes for navigation depending on whether you have a mouse or a okay, let's see here. Okay. So I'm not seeing any other questions in the chat, so I think we'll go ahead and go back into our breakout rooms. And let's see, we're at
Monica, could I
11.
just ask? I'm wondering about the timing because I know I think we're on a little bit different timing. How long do you want us to do this next section, or go till when?
Yeah, we are a little bit behind from our schedule, but I think if we spent probably about maybe 30 minutes in the breakout this time, and maybe so maybe like about 10 minutes for the first activity, and then maybe 5 minutes for the other ones, and that should bring us back around. Yeah, so we'll spend about 30 minutes, so till like 11:32.
No, quarter till.
Oh yeah, sorry. 11:42. 11:45.
And I know you were especially hoping that people make sure they save some time at the end for how does this relate to our lives and why does this issue exist?
Yeah.
Thank you.
Yeah, definitely save a little bit of time at the end, but we'll give you a little prompt along the way when it's time to move on from like that first rose thorn bud activity. Okay, let's go ahead and open the breakout rooms if there's not any other questions. Darren, I think that Linda is opening them up now, so if you still are having challenges, let me or Linda know. Jordan, I don't think you were in one before, so
Yeah, I was wondering if there's one you wanted me to join.
I think, let's see. Maybe room 6 might be a good one.
Yeah, that sounds good. Thank you.
Yeah. So thank you. I also just put a link to our evaluation in the chat for folks that need to leave early. This is really helpful to us in planning these communication network meetings, and really want to get your feedback on the session so far, and we can use that to help us plan better meetings in the future. So maybe let's go in numerical order. Is there anybody from group 1 that would like to?
Others in this space? You know, I'm in my position because of lived experience, because I was navigating all the things and now I'm here. So, you know, I think it was an interesting observation to look at the different care coordination maps, the ways people have visioned it, the experiences of families. There was appreciation for the plain language one that really like centered on one idea, was like friendships, right? Like just a basic, thing that anybody really wants in life is connections. But otherwise, I'll just share because we didn't get too much chat about what we observed. I think it is interesting to see what people thought were roses, thorns, and buds. I'm noticing there's not a lot of buds on the green stickies, but also then, pivoting over to like the why this is happening. And I just want to like acknowledge because it is really challenging right now for so many reasons. Somebody put in there, good meeting organizations and their need to survive the work experience. I just want to call that out.
Mhm. Thank you.
Yeah. Group 2.
Okay, group 3. Let's see, is there anybody that wants to share from group 3? Maybe Fair or Tracy?
Hi, I had to leave the meeting and come back in, but participated in the sticky note exercises, which I thought was really helpful. But Fair, if you were part of the communication at the beginning of that breakout, I don't know if you would want to share.
Sure. We actually didn't really discuss. We just kind of got right into it. And it was really fascinating to see. There was a lot of movement on the mural board. So it was really fascinating to kind of read as we went, or for me to read as I went.
Group 4.
Sorry, that's me in our group. I guess for the Rosebuds Thorn people, talked about just how many people really cared about this work and the depth of passion around this, and that was a really positive thing. And also coming together today was reinforcing. Then, just funding cuts and all the change going on being really challenging, and already existing issues like lack of providers and wait lists and access to specialty providers. And then in terms of what's really happening, people are having to learn both to do more with less, but also like work through a lot of emotions, loss, grief, fear. And so both for themselves and for colleagues and families that we work with, and that it's especially hard for care coordinate or people doing care coordination who are working directly with families, and that those who are a little further removed, are trying to step up, or everybody's sort of looking at how to support their colleagues. In addition to families, it's a very strange time. Let's see. And then in terms of how this relates to our lives, again, sort of being aware of other people's emotions in this time and managing your own, trying to use the resources you have carefully and not overspend, speaking up for others, and just knowing there are other people who want to help. And then why does this issue exist? Just because the system healthcare is complex, there's not enough funding, systems change is hard, things get measured just on immediate costs and not long-term outcomes, and healthcare being for profit. And I realized then that I was like rushing my group through because I thought we still had to keep going. So, so we got that done. But I was like, we've got to get through to the most important questions. So thank you group, for bearing with me.
Appreciate that. Okay, anyone from group 5 want to share?
was hoping Kim was going to go, but it looks like Kim was hoping I was going to go.
Oh, that's funny. Exactly. I was really hoping you would go.
Too funny. I was thinking similarly to group 3, where they said that, you know, they kind of just got down to action and started writing, and we didn't have as much communication potentially as we might have. But I think in looking through the different boards, there was a lot of similarity in thinking. And I'm also excited to see what our next pieces are, because we did move a little bit further down the board than maybe we were supposed to as well. But Kim, anything else you want to add?
Yeah, I think one other area that Sue and I were both actually adding into the sticky notes is the data. And I don't know that that's been mentioned in other groups, but just better ways to use data and not having enough data. And so I thought that was a really kind of out of the box thought. So yeah, but it was a good session.
Thanks. Group 6.
Jan, you want to share?
Sure. We focused on the care coordination, noticing mom or parent is the focal point for care coordination, and how that really it told a story. And then we talked about where are the gaps in that story, where are the strengths in that story, and how does our systems need to enhance or support that story, because and that everyone's is different. This was story of one family, but everybody's looks different and they need different kind of support. And how can the systems be changed to enhance that support? So the burden is not always on the parent or family for some of that.
Great. Thank you. Let's see. So next, before we go on our break, I'm going to put something in the chat. This is a survey. So in addition to the evaluation, which I posted earlier and I will post again later on, we also created a survey for this meeting. And this one is not anonymous, like the evaluation is anonymous, but we wanted this one to kind of get a sense of who's in the room and what you're working on and what specific questions you have or things that you would like to get involved in. So we have a brief care coordination networking survey that I just put in the chat. It asks you for some information about yourself and then who you are communicating most frequently with whenever you are coordinating care for a child. At several points in this meeting, folks have, talked about, okay, well, what's going to happen next and how are we going to build this interconnectedness in this network? So this is one of our kind of first steps towards that effort, is to kind of get an idea of who's in the room today and how they're interconnected with one another. And that will also help us identify kind of like who is missing and who do we need to build stronger relationships with. So yes, it is wonderful to share that, Yvette. That's a great idea. You can share that with folks that are not here today that you work with or connect with. So yes, feel free to share that that after the session as well. But wanted to share that now so you have time to even start filling that out. And we might give about a few minutes for you to fill that out, and then we will do a 10-minute break. So if you could start filling that form out, and then maybe we'll come back at 12:10 And it says agency on there. Like if you're a family member, you could just put family as your, agency or unit. And if you don't have a unit, Renee, that's fine. If you're just like, you can just, it says if you're not in a particular unit. For larger agencies, it might, like if you work for DCYF, it might be helpful to know if you're working for ESIT or, things like that. But if you don't have a unit, that's fine. You can just leave that blank. Same, but just kind of maybe indicate your role. And when in the people that you're communicating with, you don't have to list a specific person. Like if you're communicating with like the nurse at the doctor's office, like that could be like, you could just put that role, and then as frequent folks that you're communicating with if you don't have a specific person. And then there's just some questions about what you would like to learn more about. If there's anything that you're working on around care coordination that you want other folks in this group to know about, give you an opportunity to share that so that we can start, building these connections. I think one of the biggest things we've learned is that there's so much going on around care coordination that it's hard, to keep track of everything, not only for families, but for professionals as well. So how do we streamline and get aware of all the good work that's going on and see how we can collaborate more effectively. So survey is in the chat, and we will come back at 12:10. Thanks, Christine. That you can use to, if you have any kind of global thoughts on how you might make use of the information that you're doing today. And then we have some more specific questions down below that, since we're a little short on time, you might want to focus in more on these questions that are about kind of what can we do about it. So we have a set of 4 questions here that has, what would coordinated care that works for families look like? So just your thoughts about kind of what elements would be important for a care coordination system that really works well. What are the key bright spots that we want to enhance? What did we see in those, roses and buds that we might want to build on as a state? What are some of those key barriers that need to be removed? What were some of those thorns, things that are really standing in the way of families getting effective care coordination? And then what are our best next steps? So, our plan after this is to collate all this information and develop some recommendations for next steps, and also to help us with our action planning as we, are working to improve care coordination and training for care coordinators. So, what are some of those best next steps that we might take? And that is basically the part that we'll be working on next in the breakout rooms. So I think without further ado, I'll go ahead and have Linda put people back into their breakout rooms. Again, if you don't have a breakout room already, you can just stay in the main room and we'll get you situated. And we will have about 30 minutes in this breakout room. So coming back around 12:45. I am talking away on mute. Sorry about that, folks. So I just put the evaluation link in the chat, and then the care coordination network survey. And so now we're going to have just a couple minutes to reflect as a group and just kind of talk about next steps and things like that. So I wonder if there's anyone from group, could go in reverse order this time. Is there anyone from group 6 that would like to share?
I will be happy to share for the group. We came up with some great stuff. I think our discussion of how we can become empowered was really helpful, and it's quickly spiraled off some what can we do about it ideas. We did not really do the 4 different questions and what can we do about it. We just did what can we do about it.
Okay.
I think there's some actionable items in there. So kudos to my group for that.
Any examples of action items?
Well, we should be looking at funding for doula programming and
group 5.
I can go this time to save Sue, but we were talking a lot about key people that need to all be in one room, specifically around system communication. And we were also talking a lot about LEND and how there are a lot of really cool ideas that come out of LEND, and we need to find good ways to share this more openly, and also to have DOH connect more so we make sure we don't miss out on hearing all these really cool ideas. Gosh, what else? All right, Sue, I'll let you pop in. Anything else you want to add?
I think building on what Steve said also was that confusion around all the different labels for similar work. And I think it comes from siloed funding, and then you get siloed programs and figuring out and duplication and gaps. So how do we mitigate that by having shared language and shared systems? I think that's what we're all here about. So I don't know if we had any specific action steps other than trying to get some key people in the room so that we can get that happening.
Great. Group 4.
Okay, so it's hard to get the, and now I'm trying to find my thing again. So I I don't know. I think we didn't have that many concrete suggestions because I think we were getting a little bit tired at the end of the day, but we all agreed about, that coordinated care for families requires trustworthiness and what that takes to have that work. And the barriers being language, funding, long wait times, et cetera. There was some talk about, are there ways to bring more sort of specialty services into primary care, like genetics or developmental screening or developmental delays into primary care to alleviate the wait, and how could that happen? And bright spots, just by collaboration, relationships, community health workers now being a Medicaid benefit. The Washington Include Collaborative has been growing and offering more trainings, as have other places, around care coordination. And just, I think at the awareness at the legislative level about the importance of mental and behavioral health and the need to intervene earlier. And that has led to some funding increases in that area. And then the best next steps, part of it was, again, just like other people were talking about silos and siloed information, like how do we make sure we're getting information there, making sure that 211 and Help Me Grow have the most updated information. And how do we identify organizational stakeholders across sectors to keep connected so that at some level there's information sharing across, not just within public health or within medicine or within, but across those. I think that was it. Does anyone else in the group have anything they'd like to add?
Thanks, Kate. I also put in the flyer for the ECHO IDD resources, which you mentioned some of the include activities, and that's a big thing that folks can connect to. I don't know if you want to say a word or two about that, Kate.
Sure. So there's a ECHO is a way basically of having a hub team of experts, which are across the state at a variety of different disciplines, including self-advocate and family members. And it's around autism and other intellectual and developmental disabilities. And what are the resources that people who are doing care coordination need to support those patients, those students? So it's a monthly session for the third Wednesday of the month from 8:30 to 10, where a community member presents a case of somebody that they're working with and what they've done and what they would like help with, de-identified information. And it really is the whole room. And there'll be like 70 people from around the state. Chiskin coordinators are a big part, but there are many other people too, and just sharing together. And then a brief presentation. Matilda Sampson, who's on here from Excelsior, is also part of Washington Include and is working on a care coordination. Do you want to say anything about that, ECHO, that will be starting sometime? Oh, yes, Catherine. Thank you. Did you, I don't know where it is in terms of how soon it is to launching, Matilda, but.
Hi, thank you for the plug. We are just at, or I hit mute again. We're just at the beginning stages. Very excited about it. I used to be a WISE care coordinator for 7.5 years, so I have a little bit experience, especially with autism and IDD. We want to build a curriculum for WISE care coordinators and DDA case managers on coordinating care with specifically or with autism and IDD, how you work with clients that have that. I know when I walked in as a care coordinator and I had to go through all this, there is no training whatsoever, how to work with kids with certain diagnoses. So I'm very excited. We will be hitting the ground running next week at our third meeting. So
wonderful. Glad to hear about that.
Yeah, I'm
And
so happy to talk about it. And I love this. You have lots of handouts. I'm very interested in looking at the the mapping. I love that one. And just like who's all involved, like you talk about as a nation, as a region, as a country, or county. Um, Mine, I would, after this goes around in Indian country, hopefully I'll get one going for Indian country too. There's so many out there that, need that put together that training. And that way, we won't lose so many clients.
Yeah.
Yeah, and I just want to say quickly, and so the best way if you want to find out new things coming, sign up for the website, washingtonclude.org, and you can sign up for a relevant echo, but if you just sign up for the website, you will get emails about different events coming up. Thank you.
Anyone from group 3?
I am happy to represent group 3, but I would love it if Janet or Fear and any of the others would like to join as well. So we did things a little bit backwards. We decided to start out with entering information into the mural, and then we finished up with conversation. So I'll just go through and highlight a few things that we came up with. So in how can we become empowered by our new understanding, continuing the work even when times are difficult. Important to also empower our families. This is a time and a climate where it's really important that we empower our families to lift their voices and their experiences, because those are really important for others to hear, agency folks as well as decision makers, lawmakers, that kind of thing. The more we can fight, the less families have to, was something someone said. And becoming more determined to advocate for the kids and families we serve. And then just going down to what we can do about it. Had lots of great ideas around what would coordinated care that works for families look like. Families know who to call for what. Less wait lists, less appointments, streamlined referrals. Families know about and access the services they need, informed choice, family-centered, family-driven care, single application for all services, and getting to work with just one care coordinator. So we want to avoid the care coordination collision, as I affectionately refer to it as. Hey, would anyone else from my group like to talk about the bright spots?
We have about 2 minutes left, so we might want to try and
Okay.
get a minute at
Okay.
least for groups 1 and 2.
Okay.
Anybody from group 2 want to hop on? Share briefly.
Well, this is Jen. I'll share really quickly. So we had the pleasure of having Sarah Forrester join us. She only could pop in for a brief time, but the time that she did, she was able to just share some updates from Informing Families and the ARC of Washington. And I think something she did point out, though, is again, care coordination is not going to matter if there's no providers to point to. So we have to acknowledge that. And then I think I would just do a shout out in this moment in time. More than ever, people have had the ability to learn why Medicaid matters. So from whatever campaign, if the ARC did that, others, the Washington Hospital Association. So that's the bright spot, but that work definitely needs to continue. People have to understand why we will all be impacted with the decimation of Medicaid and our healthcare system. So that's an opportunity. Thanks.
Thank you so much, Jen. And then Astrid, I see you on camera. Are you going to share real quick about group 1?
All right, Emily, do you want to share? You captured it all. Go for it.
I'm happy to. All right. So
Just briefly, I think one of the biggest issues that we found was barriers of a variety of sorts, right? Basic needs, access barriers of all different kinds, that sort of thing. And what we came out in terms of best next steps was kind of, again, improving collaboration and communication. So maybe getting ESIT providers to request access to their local Epic Care link so they can communicate with hospital or other systems that are using Epic. Having ESIT providers do the Chishkin Care Coordinator training, recording those trainings, because that would just be additional information that'd be super helpful. Incentivizing a variety of things, screenings to be done, ways to recruit more OT, ST, PT, ABA therapists, or incentivize schooling for those folks to increase access. So those were some of the next steps we came up with.
Okay, great, wonderful. Thank you all for sharing lots of great ideas here. So our next steps are we're going to be compiling all this information and kind of using that to develop a set of, highlights, challenges, and barriers and recommendations for next steps, and also be using this information to kind of plan how we're going to be working as a state children and youth with special healthcare needs team on our priorities around care coordination and in our action plan over the next 5 years. So really appreciate everyone's time today. We will be, continuing to connect with you and sharing out the, summary of the results, as well as the recording and things like that will be posted. And usually it takes about a couple weeks to get the recording and everything posted, but we will be sharing that out as well as minutes. And thank you so much for your time today. It sounds like this was a really, great discussion that folks were having, and I really appreciate all of your input and spending 4 hours with us today. So really appreciate it. Thank you all so much.